Hi, everybody, and welcome to today's webinar. The title is From COVID-19 to Monkeypox, How to Apply the Lessons Learned to the New Outbreak. This is part of the series produced by the European Health Management Association. The series is called Health Management in Action, Fostering Health Systems Resilience. And it's co-sponsored by the European Commission, so we thanks to their support. So today, for the webinar, we're going to be joined by Mr. Peter Tinnemann. He's the Director of the Public Health Authority of the City of Frankfurt, and he's the Head of the Global Science Unit of the Institute of Social Medicine, Epidemiology and Health Economics of the Charité in Berlin. Peter, thank you so much for joining us. So what is he going to talk about and what are we going to cover? Well, you'll see that in a moment. I'm going to give you a short 10-minute introduction, and those of you who come regularly will know it's much quicker than that. We'll have a 10-minute presentation by Peter, which will be about applying lessons learned from COVID-19 to new outbreaks. And then after that, it's time for Q&A from you. So, so we really want to give you an opportunity to have any of your questions answered. And if you want to share your reflections, then that would be a great opportunity. This is the 9th webinar in our series that we've run this year. It's been called Health Management in Action, Fostering Health Systems Resilience. We've discussed topics like health management topics that are crucial to improve health system preparedness and response. I know that some of you I can see in the audience have attended several others, so you'll have a good sense of how these work. For those of you who haven't met Emma before, we have a vision of excellent health management for a healthy Europe. The way we do that is by supporting the spread of knowledge on effective health management, and these webinars are a great example on spreading that knowledge. And everything we do is with our values of excellence, quality, inclusiveness, relevance, and respect. So you should expect that way of working every time you deal with us, and I hope you see that today. A few other things about Emma, if you haven't met us before, is that we are the only membership organization in Europe that brings together the full diversity of the health management ecosystem. We're a recognized and respected amplifier of best practices in the evolution of health management. And it's important to us to provide an environment where evidence, challenge, and experience are valued, and where complex debates on current topics can take place, which means today you can have a complex debate. If you're up for it, we welcome your comments. And just finally to say, if you're not already an Emma member, we'd love to hear from you. Do check out our website and feel free to become a member. We have organizational members, but we also sometimes take individual membership if you're not part of an organization. And it really is our members that help shape the structure of these webinars and the topics. So do check that out. But what you're here for today is to hear about the presentation from Peter. And so, Peter, I formally welcome you and thank you so much for joining us.
Well, thank you, George, for the invitation, and I will start right away so we don't waste any time. And let me just check. My slide should be on. Hang on for a sec. No, that's the wrong picture. There you go.
Yep, we see it.
So I run you quickly through my short presentation. As you said, I am the head of the Public Health and Health Protection Authority of the City of Frankfurt. To give you a bit of a framing, Frankfurt is pretty much located in the center of Germany and therefore also in the center of Europe. It's a huge financial influence city. The European Central Bank, the German Central Bank is here. Roughly, we have a population of 250,000 people, and we have about 250,000 people commuting into the city every day. The airport in Frankfurt, for which we as a public health authority are also responsible, has as a maximum capacity per day another 250,000 passengers every day. And we look after those as well. The Public Health Authority is around 300 heads, 300 people that work with us daily. We get a lot of question and beaten by the German media at the beginning of the Corona pandemic. We were always portrayed as the ones still using fax machines, which in fact, we don't really have fax machines in our office anymore, since most of the faxes arrive at our emails. but we still have to be able to receive faxes because this German system is not yet very digitalized. Unfortunately, I think we'll see massive changes in the next 2 years, but that's where we are. It has annoyed us quite substantially because the picture was, I think, quite wrongly portrayed in the German media during the beginning of the Corona times. Everything that we do as a public health authority needs to be within the remits of the law. It's basically called in Germany Vorrang des Gesetzes. So we only do things that are covered by the law. And for everything that we do as well, we call that in Germany the Vorbehalt des Gesetzes, there must be a legal basis. That's important for you to know because also sometimes we're seen as an authority and not flexible enough and we can't adapt to new challenges. But in fact, we can't just do things which are outside our remits. I want to run you briefly through what we do every day. We're responsible for infection control. So during the Corona pandemic, it was our main task. In fact, more than 300 people. We almost doubled our number of staff working just on contact tracing, looking after people who are needed to be sent into isolation. We also have the authority over municipal hygiene. So, for example, we look after the quality of drinking water. So we are the ones checking the water services. We're responsible for disaster management in the city, specifically all the health aspects. We do official medical examinations. Let's say somebody wants to become a public servant, they have to be checked by one of our physicians if they're physically fit. We do a lot of work in child health. So every child in Germany needs to go through a checkup by the public health authority if they're fit or if they have any challenges on their eyesight, on their hearings or physical disabilities that hadn't been detected yet so that they're ready and fit for schools. We are in charge of community psychiatry. So if somebody with a psychiatric disease is released or discharged from a hospital and they need further support, this is what our social workers do and our physicians are doing. We're in charge of environmental health, and in particular, it's not really clear yet our role in climate, in health challenges by the climate crisis, but we're looking after private houses or public buildings where there might be a contamination through molds. We have a dental service that we provide to children. We do a lot of prophylactics works there. We do humanitarian medicine. Everybody who cannot access the German public medical services can still come to us. That's a very unique service that we offer from the Public Health Authority in Frankfurt. We do a lot of preventative medicine, and that's really also why we were involved in providing immunization service and for the larger population during the Corona crisis, and later on also through the monkeypox outbreak. But in fact, in Frankfurt, we do a lot of vaccination consultations as well for people who want to travel abroad. They can come to us and receive any kind of vaccination from us. And then we do traditionally lots of health communication, basic things like leaflets on ticks or head lice. Increasingly, we are also involved in social media efforts to try to educate people on whatever is going on. And we've just it's one of the learnings during the Corona crisis that we've set up its own communication team with a newsroom where we monitor social media, monitor what's happening on TV, and actually open up channels so that we can better communicate with the general public. And then came all this. I mean, you're all aware of this. A bug that started somewhere in China had arrived eventually here. And in fact, in Germany, it arrived first by plane through a group of people who were evacuated from China by plane into Frankfurt. And here's a picture of the team that was ready, because we are then the authority coming in, receiving people with potentially infectious diseases. We checked up everybody, as you see here, packed up in protective gear. That was the first airplane that arrived. And already there, in retrospect, it was quite evident that simple masks in the plane helped to prevent spread from those who were infected with the virus. They didn't really pass it on to everybody else. The question then was, and I think that was the very first part of the Corona pandemic, especially for us, what measures need to be put into place so that we can contribute to the risk of reducing the risk of transmission. And then eventually, the major breakthrough, I think, happens when vaccination or vaccines arrived. Now, here in the upper part, you see This upper picture, this is the main event hall in Frankfurt. You see in the lower part of this picture, this was cabins and services that we had set up to be able to vaccinate up to 4,000 people per day. It was a vaccination machinery, really. We never reached full capacity over the whole periods of the time when we had set it up. But basically, it was one of the challenges was that we got the order by the government in December 2020, get ready by the end of the year within 4 weeks to be able to administer vaccinations. And eventually we were able to vaccinate the first persons in January 2021. But saying it wasn't us who did the vaccination. We had a very, very close support and collaboration with civil society organizations like the German Red Cross and others who did provide us with staff, etc., personnel who did it. And what was quite crucial as well, the location where we did the vaccinations was part of the exhibition area in Frankfurt. It's an exhibition area that hosts international exhibitions of all sorts. And as you can imagine, they were absolutely prepared and ready to set up whatever we needed, literally over time. All the stuff that you can see here was basically rented from them, and it was their services, including their IT services, that set it all up for us. So that was quite a very good start that we had there. But the things that we learned, really, I think we can put under the overall heading of everything was new for us. Although we had preparations in place in terms of pandemic preparedness plans, they weren't really adapted for setting up vaccination areas, and we'd never done it before. So it was over time only learning on the job. It was bringing in new people that had never done what was needed to be done beforehand. So there was constant discussion, constant communications with our staff, with staff from external organizations, with the exhibition area, exhibition company, so that it all worked out. What was very interesting for us, maybe anecdotally, our staff that we used in the huge vaccination center was a lot of Lufthansa air crews. Lufthansa has one of its biggest base in Frankfurt, and they weren't flying, so they had a lot of people with service experiences that we brought in for the first couple of weeks, and they really had an amazing way of dealing with people as if they were passenger in the air flights, and it was very easy for them to give them to understand structured information. This is where the patient comes in, this is what they need to know, this is what they need to go, etc., etc. The literal immunizations initially were done by lots of retired medical doctors. As you can imagine, doctors were looked after in hospitals in their private practices. So we brought in a lot of elderly, and they were over time replaced by younger physicians. What was new to us was the IT infrastructure. There was no IT infrastructure that was set up already for documenting, preparing, and analyzing the data that were coming out of the daily vaccination efforts. And then obviously, not only on state level, but also on federal level, the other authorities and politicians wanted to know what is going on. What are your challenges? How many patients are you using? And as you might remember, at the very beginning, we did not have enough vaccination, so that we needed to ensure that only those groups, at least that was the system that was set up in Germany specifically, the high-risk groups were vaccinated first. So we needed to be able to check for each single dose which person is coming in, is getting it, and have they registered beforehand. Are they receiving it? It was an extreme new area of dealing with data and setting up this whole IT database infrastructure on the job as well. The analysis, what we were asked about how things are moving forward, how we are processing, was often changed on a weekly level. Politicians wanted to know, that was at least the feeling on the ground, new things every week. And the system needed to be adapted to this. but that has its consequences on the pipeline of how we worked. We needed to change processes, adapt them constantly. Data security, since who we give access to which kind of areas of the data was uncharted territory. It was new to us to make sure that we actually have the highest standards of data protection. Vaccine logistics, it was another big area that was entirely new for us, but also for pharmaceutical services, because this was the first time that vaccines were purchased centrally by the federal government, and then it was distributed at the time also with support by the German army to the local level. There were a lot of fears at the very beginning that the distribution might be attacked, that people might be ready to violently acquire the substance, which didn't really happen. But it was there was a lot of security questions initially, and it needed to be put in place. It was outside the regular distribution of medicines and vaccinations that we usually do, as I guess in most countries, through a established vaccination system at large. What was also new for us was public communications. I mean, we have regular communications on, please get your regular flu shots, get this shot, get that shot. But here we had to deal with a lot of uncertainty and a lot of new information that needed to be processed, presented in new ways, thought about how we give it to which kind of specific groups, which led again in our public health office to have regular discussion with a new team. Initially, it was just 2 people working on basic communications. We now have a team of almost 8 people who do not only health communication, but also a lot of communication on dealing with media, dealing with TV teams, etc., etc. Also that needed to be set up. There was a lot incredible media interest when the vaccination center was opening its doors. TV crews, they wanted to come, they wanted to film, so that needed to be all be put in place. And then over time, as my last point on the Corona vaccination center lessons learned, was really that it was unclear from the very beginning, how long are we going to do this? And if we only doing it for a certain period of time, how will it be done afterwards? Essentially, we were told 9 months later, stop vaccinating, close down all the vaccination centers and give it to the general practitioners, which in Frankfurt, we followed the orders. We closed down the vaccination center, but basically moved from the 1 mega hall to a smaller hall. And initially we said we need to be able to do another 50 vaccinations on a daily basis. Then came the next winter period. There was increasing interest again into renewed shots. So we then expanded again to 500 vaccinations per day, and we were ready to do it. In fact, we were the only city and area in Frankfurt who maintained against the order of the government, or I'd say sort of by deviation of the order, in Frankfurt to have a vaccination center. And people from all other areas surrounding Frankfurt came to us to get vaccinated. Now, what did we learn to bring into the monkeypox situation a few months later? There you go. Now, again, we're challenged an old vaccine or a new disease and a new vaccine. In this case, it was a bit different. The vaccines that were used were existing vaccines. They were used, so we didn't need to talk a lot about what we were using, which was a lot of discussion in the Corona days. But here we had a lot of questions because federal government kept it unclear. They gave us orders, please do vaccinate, but it was unclear who will pay for this. And this sounded a little bit sort of almost unmorally, but in fact, for us, it needs to be clear when we do a job, who will give us the money for the people so that they are paid for when they do the services. And that took quite some time and was not dealt with as flexible as it was in Corona time. Governments, politicians were much more hesitant to be clear on this and take quick decisions. Again, a purchase of monkeypox vaccines was done federally. And again, it was done distributed to the local level, where again, we had no influence over how much substances we would get. Now, Frankfurt, as Cologne and Berlin, big cities with a large community of men having sex with men, we had a lot of people who wanted to get the vaccines. Some other areas, more on the local countryside, where there was no interest, they still received amounts of doses, but didn't really have enough people who wanted to get any vaccination. So that was something, I guess, which needs to be addressed in the future. Oops. What is that? Which needs to be addressed in the future and looked at how we actually distribute substances to the local level. Here in our region, we managed with the surrounding public health offices to actually, in a very collegial discussion, we said, if you don't need it, send it to Frankfurt. We have a lot of people who want it. So it was done more on a informal level. In terms of communication, as within Corona times, there was no central communications. We needed to get into the system, find our own ideas, find our own ways of communicating what we wanted to communicate. Again, in logistics, we're pretty much on our own, how to store it, how to distribute it, etc., etc. A big difference compared to Corona was that here we had a very defined target group of men having sex with men, still until today. It's mostly that community that is looking for monkeypox vaccine, which was entirely different beforehand, where we had mostly the general overall population who had an interest in Corona. So there was some similarities, some major differences in between both ways. I think for us, we are now pretty flexible, and we will be maintaining abilities, including maintaining staff who can do vaccinations, so that we are ready and prepared for the next, whatever will come. We will be having the expertise and having the logistics in place to be able to vaccinate in the future. So that was this from my side. Looking forward for your questions, and I'm happy to discuss and learn also from you if possible.
Thanks very much, Peter. That was really very interesting. I know I have a bunch of questions, and I also just turned to the attendees to say, you're welcome to switch on your camera and your microphone if you wanted to directly ask a question. If you're more comfortable, you can also type it into the chat. Peter, to start off, I wanted to ask about how decisions are made around healthcare system changes in Germany, because I understand that you have a really regionalized way of decision making. And what I was hearing in your presentation was when decisions were made locally versus what national leadership you were looking to. Can you say a bit more about that model and what you had to factor for that, for maybe COVID versus monkeypox?
Well, in general, any issue that is related to health is dealt with on the state level. We have 16 different states, and that's where the responsibility lies for health. We have a certain legislation in place that gives us responsibilities on the local level. So then when it's delegated to the local level, that's where we take over, and that's when we pick up and we're dealing with this. During the Corona crisis, there was a lot of discussion. It's a disaster. We need to make central decisions and just tell everybody on the local level what they are supposed to be doing. Now, I think that system, when it comes down to vaccines, brought its own challenges. I think in that sense, the biggest challenge was that the established logistical systems, communication systems were sidetracked, and often decisions were made on central level. They were almost given by order to the local level, and then it was up to us to implement it. And that's not how we usually work. In fact, we know much better what is needed and how we can implement things on a local level. So a more decentralized decision-making, which is the way we usually work, is much more helpful for us compared to a centralized decision-making.
So then theoretically, could a region decide, or a state, what do you call them? A Bundesland. Could they theoretically decide not to respond to monkeypox as one example? Like, do they have full autonomy? Well, in infectious diseases, we have a federal law which rules and regulates how we deal with infectious diseases. Everything, and I think that makes sense, because here you're dealing with outbreaks. They often spread across different states, Bundesländer. So when the federal government makes decision under this federal law, then the states can't do anything, right? But everything that is not rules on the federal level
that's up to the state level to take those decisions.
And then how is it coordinated? So are there, like, you have existing mechanisms on how public health institutions come together?
Well, there's regular meetings, regular flows of information that are used that are established and used since ages, let's say. During the Corona crisis, there were different task forces set up for clinical care, for vaccination services, and it was basically then new communication structures set up as well, with new people, which changed at times also quite frequently. Sometimes you would see similar faces or faces that you knew from the past, but there was certainly one of the biggest challenge. How do we spread information? I think what was one of the biggest challenges that most of the communication was either done initially by phone, later on by video conferences, but also at the same time by email. And I think there we have currently, with tools like Slack or Stackfield, other ways of communication, which most people are not very used to, you know. So I think that's something that we need to address in the future as well, which kind of communication tools we really use. As here, video conferences are now very established, but I mean, even for us, it took quite some time to implement that in our office, to get video cameras and get the facilities for everybody to be able to use this type of communication.
Yeah, yeah. I saw you showed a picture of something you called a fax machine. I've never seen something like that before, but I've heard of them.
I need to go on the web to find an old picture.
Yeah. So there's a question from Margaret Johnson. Welcome, Margaret. You ask, you thank for the presentation. You say that you're aware that during the monkeypox outbreak, people from Belgium were crossing the border to France as it was easier to receive immunization in France. Can you tell us about government access policies to vaccination in Germany? So I think,
well, it's generally only responsibility for the population that lives, for example, within the city limits of Frankfurt, right? Also with the corona, I mean, it was pretty much distributed along those municipality borders. But in fact, I mean, on the ground, we never asked for identification. Are you from Frankfurt? You know, are you just here for the day? And similar with monkeypox vaccination. We had Americans who were on a party on the Canary Islands. They ended up in Frankfurt. They were diagnosed here, and we took care of those. You know, I mean, that is covered under the infectious disease legislation, so that we can say everybody who needs our support as a public service, we will be able to take care of those. But on the other side, they're not the ones which are our regular target group.
Yeah, indeed. So obviously for infectious diseases, there's enhanced controls around how you would provide healthcare. So we see that in many countries. And I wonder then also, you talked about it being contained, and it's been described in Europe, monkeypox has been described as being contained to, at the moment, to men who have sex with men. And I haven't followed closely the epidemiology, but I assume it still is considered contained within those groups. And do we feel like are you seeing a shift in the response in Germany? So, for example, at first WHO declared something of interest. Has there been an update of its status?
Not in Germany. Numbers are going slowly but steadily down. I think the initial hysteria is maybe a bit strong, but I mean, there was a lot of discussion. It will spill over to other population groups. Children might get infected. You know, there was a bit like the 1980s, 1990s discussion with HIV/AIDS. I think we've managed to handle it in a very professionally manner. So we said we have a vaccination. We know how to isolate people. Most people were very, very responsive. So I think it's been contained quite okay. On the other hand side, I mean, similar with the discussion around Corona in Germany at the time, there's a question of if we should still give public isolation orders to the general public, or if we say now, hey, listen, it's 2.5 years with Corona. You know, when you have a sore throat, stay at home and make sure that you take care of yourself and don't infect other people, you know. And I think that sort of, we're seeing a similar way of dealing with Corona and monkeypox in that sense as well. It's not been dealt with at the high infectious disease major threat for the general population. So I think that's changed.
Yeah, because spread is considered to be through skin-to-skin intimate contact. Is that still the way?
Very close contact, yeah.
Yeah, And so then that also has me wondering about the groups that we're discussing. So thinking of it being at the moment contained to men have sex with men, they're already, my understanding is, quite engaged with health systems. So they'd be, I'd assume, attending more likely for sexual screening of STIs. They might be accessing things like HIV pre-exposure prophylaxis. So we'd have an active connection. Has there been any discussion around about reaching the right people with the vaccination, and maybe not providing vaccination to people who are not at high enough risk?
Well, I think the question you're asking, are we getting those people in prostitution? You know, in Frankfurt, we have an area around the central train station. There's a lot of drug addicts, a lot of red light districts, a lot of brothels. Are we getting everybody who's at high risk? In fact, that's the challenge to get the right people is not new to us, right? We have services for prostitutes, male, female prostitutes who come into the public health office. We are known within the circle of that community, so that I think we try to get them who needs us, but we will potentially miss some. Within the men having sex with men community, I think it's been very openly dealt with in Frankfurt. It's a liberal city. A lot of people from that community, but also others, have contacts with regular infectious disease specialists. And we did initially provide the vaccinations against monkeypox to those doctors as well, and they could give it to people that they know were at high risk from the community, so that they contributed significantly also to the distribution and to the eventually to the containment of the outbreak.
Okay, that's interesting. And another part of my question was around how do you prioritize people at higher risk? And so by that I mean, I worked previously on HIV pre-exposure prophylaxis, and when we were providing that to the community, there was a limited availability of the medication, and so we were developing a risk profile, and you had to match a particular level of risk in order to be prioritized to be started on HIV pre-exposure prophylaxis. Did you have to do any rationalization like that for monkeypox, or was there sufficient vaccination to be able to provide it to anybody who asked for it?
Well, it's the same way of triaging as we know with other diseases. Initially, when the amount of vaccines was limited, we focused on those people that we knew that they had contacts. You know, we didn't offer it to everybody who just thought of him or herself being at risk. Currently, there's sufficient vaccine supplies. We still have a couple of hundreds in stocks, and the community who's interested, we can currently make sure that they get their shots. It goes on very orderly. We have a website where they can register for a particular date when they want to come in, and we don't see any fears currently of those people who want to get a shot that they wouldn't get any. So it's calmed down.
Okay, I see a few more questions in the chat, and I'm going to come to them at a moment in time. And I'll just also say to anyone else in the audience, we've got about 5 or 10 more minutes. So if you have a question, please don't hesitate. I wanted to ask you about lessons learned from COVID again. So thinking of monkeypox, did you feel like anything new had to be done for monkeypox, or were you able to rely on what was learned from COVID and everything else we've done in history and able to just tap into all of that good learning? Or did monkeypox itself give you another set of new approaches that had to be developed?
Well, I guess in overall, doing vaccination campaigns is not new to us. I mean, if we have a meningitis situation, a measles situations, we had regular strategies and procedures in place how to vaccinate a particular group. So that's not new to us. In Corona, everything was new. The scale was entirely new. So that was substantially different. In monkeypox, although we did have vaccines, and the community was new, but it was partly dealt with on the federal level. So that was also something that we had dealt with during Corona. So monkeypox times was almost like a mixture of all different sorts, right?
Yeah.
And it was not Corona, everything was new. Monkeypox situation, something was new, something we knew just from the recent Corona outbreaks. Some parts of things, how we some parts of the things that we did how we do it did it in the past anyway, you know, with other diseases, and some things were new. So it was a bit of a mix, I would say.
Yeah, okay. I'll come now to finish off with the questions in the chat. There's quite a few. Some of them we've covered. So Anna asked a question about what have we learned that COVID didn't already teach us. So Anna, hopefully you've had that answered just now by Peter. Annette, I see a few questions from you. And so your question on that you, Peter, you mentioned several times that you can do what the law allows to do. And in normal circumstances, it provides clarity to the tasks. But is this a good practice in the moment of crisis, or would some different flexibility be welcome?
That's a pretty fundamental question. I mean, we live in a democracy, and anything that we do needs to be based on existing legislation. So we can't just do whatever we want, especially if we are a government entity. You know, I can't just go out of my door and do whatever I want just because I work for the public services. So, I mean, for me, and that's the way we work in democratic societies, we need to have legislation. We need to think about how, if we can get changes in legislation faster, or specialist advice transformed into legislation faster. But I mean, we will always work within the remits of the law.
Yeah, and I wonder if that's what Annette means in her question, which is within the remits of the law, there'd be times where it acts too slow in order to prevent a rapid response. And are there lessons around legislature that we could learn to enable faster responses that are still within the rule of law, but enable faster decision-making than going through parliamentary processes?
Well, I guess at the beginning of the Corona situation, the adaptation of the infectious disease law on which we base our actions was done within 2 days through a parliamentary process. That was unheard of, right? It was just the fastest that we've ever seen. That was good. On the longer run, governments maintained that approach in other circumstances. And I think it is time, at least now, to get back to parliamentarian processes, because that's how you offer, in a democratic society, everybody also participation in decision making, right? And if you do things too quickly, you might do the wrong legislation, and you're not taking people with you. So then you have groups of people who are getting upset and question the decision, and it's difficult to communicate. You know, we don't have a monarchy in Germany where you can say, like, this is the order, everybody does it. It's a way of our democratic systems work, and that makes them slow, and we have to accept it to a certain level.
Yeah, okay. Evelyn also asked the question around use of different types of staff roles, and I think a question came in before you were mentioning some of the ways that you use the military, the Lufthansa crews and other things. So maybe I'll just add to Evelyn's question to say, you used the workforce differently during COVID. After that, have you made any additional adaptations? Did the health system go back to the same old way of working with the same professions, or have there been changes in job roles? The answer is yes and no. I mean, during the Corona pandemic, we almost doubled, tripled with the number of staff we had working for us. And we had people that worked for us who'd never seen a public health office interior before, right? So there were people coming in with entirely different professions, and they just contributed. Now, some of them were really interesting from their basic skills that they trained on, but also from the way their personalities are. And we try to maintain them and integrate them. And as I said, for example, communication was an area, or digitalization. We suddenly had like people with IT skills that we did not have before, digital skills that we then got on board and maintained them. And that was very, very new to us, you know, where we have established process. We need a doctor, social worker, administrator with this and this and the skills. And then there's this long government process, how to find them, how to get them on board. It takes months or weeks, sometimes months. Mm-hmm. During Corona, it was like a really crisis setting. People walked up to the door, it's like, what can I do? It's like, oh, nice that you're here. We dragged them in, put them on a phone and had them do things. And I think that was a very interesting, a new approach for government services as well. And also gave our staff new ways of thinking and working. And I always say, like, we
transformed almost from a very boring, dusty public office to a modern startup. And to maintain that spirit in a government office and have people still work that way, that's currently a big challenge.
Great. There's another question from Annette, which is on lessons learned for, so she says, can lessons learned be applied to regular vaccine administration as well? For instance, from digitized processes, point of view, vaccination cards, etc. So did innovations come from maybe monkeypox that have made you think differently about the processes for administering vaccines?
Well, for the city of Frankfurt and our vaccination service that we had before in place, we had a small, say, digital solution that was handmade in-house, you know, and we always tried to convince the state government, let's just beef that up and expand this. But the idea was, no, we need to start everything. This is new. Everything needs to be done newly. But I think what we have learned is things can be developed very quickly and we won't be able to go back, right? I mean, now to move back to a service that if you want to come in and be vaccinated, to call somebody is not acceptable anymore. And I think that's something that really helped us also to arrive as government services in the 21st century and digitalize in warp speed at times. So I think that is something that, again, we need to maintain and integrate that or bring that systematically in the way we function.
Well, that is a great note to end on, Peter. You've shared so much expertise and insights and learning. I really thank you for your openness and generosity in sharing the great work that's been done in Frankfurt and your generosity in sharing that with us. Thanks everybody for the questions that you've asked. They've really helped us to have a good discussion. Right now, one of my colleagues is putting into the chat a link to the 90-second survey. And like I say, every webinar, it takes me longer to explain the survey than it'll take you to fill it out. It's really just 3 questions about how today was useful. And the feedback of the survey really helps us to choose the topics and to make sure that we design them to your needs. So please do spend that time filling it out. Okay. Now, don't forget to get into your diary for next week or the week after our last webinar, which is the legacy of COVID-19. It's the last one in this series of 10. So please do get that in your calendar, register for it, and we look forward to seeing you there. And I see lots of thanks in the chats. Thanks to you all for attending. And Peter, really, once again, thanks to you. And
thank you for the invitation. Take care. Bye-bye.
Take care. Bye. Bye, everyone.